Hello, everybody. Welcome back to the Mold Pros webinar series. Today we have Dr. Cochran, who is a practitioner out of the Seattle area, who's going to be sharing his info and case studies on how to use intravenous support on dealing with mold and mycotoxin cases. Obviously, there's lots of different ways to treat mold and mycotoxins. And obviously, there's no set protocol for doing it. So we're always looking for new avenues to help, especially for practitioners that are willing to learn and to help make sure that patients can make informed decisions when they're seeking out practitioners. So today we have Dr. Cochran, who is also going to be speaking at our Seattle event that we're going to be holding in June. We're very excited about having him for that. So if we'll be having some Q&A right after his talk, and I'll be hosting that. So if anybody has any questions, feel free to put them in the Q&A section at the bottom of the page. So after that, I'll be going to leave it to Dr. Cochran.
All right. Thank you very much for having me. So one of the things we're going to talk about today is why in my clinical practice I find IV nutrient support so helpful for practitioners and for patients, whether you're a practitioner watching or a patient watching this. And some of you may be doing this, or some of you may be new to this information, and the reason for this is I'm going to specifically talk more case study focused of showing you where I've intervened or used this in some patients, and then what I've also looked for in some more sensitive patients, because we know most of our patients that come in, we're dealing with mold mycotoxins, often have a huge gambit of sensitivities or reactivities to multiple different things. Once they've been exposed to mold and mycotoxin issues, it can come up. So these are my affiliations or disclosures. This is also my contact information for anybody that does need to get a hold of me. And this is also my website if you want to keep track of what I'm up to. So with that, let's kind of get started. So one of the things why, again, just a brief introduction, why I like to use IV nutritional therapy in most of my patients is depending on the severity of your patient with mold, oftentimes we find that they come in, and you've probably seen this too, they have a severity of GI issues and multicellular dysfunctions that if we were to use oral routes only, we will often be chasing for years rather than months. And we may not get that person well just because their pathology has gone so far that oral nutrition is not enough to get it into a cellular department. So this is a strategy to do that with people. Now, we do have some patients that do this, that they've been in mold environments for several years, and then it was discovered, and then they're trying to get well, and they do tolerate these things very, very well. And then we have other people that are extremely sensitive just to any oral thing you give them. They can be sensitive to IV things. Now, one thing that you will notice is, and is worth a try, if you have that person who you may be that notices, I can't take these oral things because I react to them, it's possible that it may be such a microbiome issue because of the mold exposure that you don't tolerate oral things, but you can tolerate them being given into the vein or directly into the cellular compartment. In other instances, there will be those cases where that is absolutely not an option and you just react to the ingredient all the time. So this is an example of a 50-year-old female. We had allergies to mold. This is a patient of 8 years. They initially presented because they were having recurrent ear infections and sensitive TMs. tympanic membranes, basically. And they came into me initially because they were having a history of recurrent ear infections with rupturing eardrums. And this is not just in their childhood, but it continued to go on into their later adult years. And they're so sensitive that literally, if they get on a plane ride or they have any elevation change, even in a car, their eardrums were very, very sensitive to the pressure changes. And again, when they first came in, they were having lots of recurrent ear infections with the rupturing of the eardrums. So despite, conventional care is to put ear tubes in, and despite that in the past, this didn't work for this patient. So they came in, initially their eardrums would bust about every 1 to 2 months. We discovered they had a dairy allergy. Most people that I see that just have common run-of-the-mill ear infection-like symptoms that are chronic or have tympanic membrane issues, I usually find they have a dairy, egg, or gluten allergy. And this person specifically, it was dairy. Upon removing the dairy, a large majority of the symptoms did drop. So the recurrent ear infections and the rupturing cycle did drop off quite a bit. And we did have to use topical drops, both from herbal and like oil, like garlic, mullein oil. And also we did use some mild corticosteroids and mild antimicrobial, antifungals, and antibiotic therapies for this person while they're going through this. Now, their history was, after we kind of got the acute issue dealt with, was that they would get these ongoing spring and fall allergies, and they get the postnasal drip, and then the ears would flare up. So even though we got them fairly stable, they'd still have these rolling cycles of flare-ups. In 2020, it came about that not only was she having these flare-ups, but she's also having these GI issues that were becoming more apparent. And she was treated for SIBO. Now, for those of you that either have mold or have worked with mold, you find mold exposures and SIBO can be very common, or mold exposures and dysbiosis are a very common thing. So this came up then, and it kind of further drived, hey, there's something deeper going on here. 2020, later, after we got the SIBO managed, we decided to look a little deeper because of this ongoing ear issue and also the SIBO issue. And we discovered that there were mycotoxins, in a significant amount of mycotoxins actually found in her urine. I believe it was OTA and citrinin, and then some gliotoxin that was found in her urine test. Upon further searching of that, of testing her home and her vehicle, and then her workplace, which is at a dental office, we found that she had, the room she was working on had discovered some mold that had been getting, in there because of moisture intrusion through a window that had failed at work. So since then, that has been remedied and fixed and cleaned up. However, what we were doing during that time frame was, okay, what do we do besides keep you away from that work environment for that period of time? What do we do as part of your treatment regimen? And my focus here is going to be, again, more on the IVs, because you're hearing all these other people talk about other oral interventions. So what we started with her was intravenous PTC, which is also called phosphatidylcholine. Now, the only contraindication with phosphatidylcholine that I often see is if your patient or your person has a soy allergy. Most of them are derived from soy in the intravenous form. In an oral form, we can get things that are sunflower-based, but we cannot in the IV form. We also did glutathione with that, which she actually tolerated very well. And depending on your severity or sensitivity to mold, some people will not tolerate glutathione at all for a period of time, and they'll only be able to do intravenous phosphatidylcholine. So we started with intravenous phosphatidylcholine mainly because she was unable to fully remove herself from the incident or the environmental until it was remedied. And mainly I wanted to do that because phosphocholine is a good cholagogue. And so it's moving bile, which we know a lot of mycotoxins need to be moved through to exit the body. The other thing that it does is it's really important in cell composition or cell membrane composition. So as toxic stuff gets placed in the cellular composition, we use phosphocholine to try to kick out some of that toxins and replace the cell membranes for fluidity. So that's my thought process with doing that. Now, you could definitely do nutrient infusions with other B vitamins and vitamin C, and she previously had done some of those before the discovery of the mold, so we just kind of transitioned to doing this protocol. Now, typically speaking, phosphocholine with glutathione and glutathione dosages start at 600 milligrams and will ramp up to then, if tolerated, 1 to up to 4 grams total. Some patients, again, that have mold will not tolerate glutathione, or you'll have to go much slower with them. And they are the patient that often needs a lot of molybdenum support because of slower SUOX pathways or sulfur metabolism pathways. So we did this for 20 infusions. It's not uncommon with phosphocholine or glutathione to be looking at it up to 30 plus infusions. That could be once a week or twice a week infusions. And then what we noticed is slow improvement of her symptoms. So basically less of the fatigue, less GI issues, less of a little bit of the brain fog she had. And then basically we were also tracking her mycotoxins and seeing initially they went up and then they started to drop. Most of you that know, if you've been around mold and you're doing something with mycotoxins, it's not uncommon for, as you're getting the system to detox, you'll notice the mycotoxin urines will go up and then they'll start to drop off. So the environment basically is remediated now. When I wrote this lecture, it was undergoing remediation. So what we've basically transitioned to now is she's not needing to do the IVs anymore. Things have been improving and she's been on purely an oral regimen. So that's one case. Now she's not your typical very reactive mold patient. She was actually mostly up here in the TMs and a lot more nasally, sinusy stuff. I believe, if I remember right, we did work her up for Marcons, and she did not at the time have Marcons or mold colonized with a microbiology test at the time. So any patient, again, and if you haven't seen these yet, anybody that has like recurrent ear infections or a lot of sensitivity on the tympanic membranes, I would definitely peruse that idea of the person getting exposed to mold. This next one is a 21-year-old female. She actually had fluoroquinolone toxicity that was diagnosed by me. It was missed by her previous providers. This all started after she got an upper respiratory infection. She got an upper respiratory infection, and then, well, I should say, she got a urinary tract infection, and then she was put on fluoroquinolones, and 1 dosage of fluoroquinolones. She woke up the next morning with extreme pain and weakness in both legs and extreme fatigue. If you haven't read about fluoroquinolone toxicity, you'll see that's very common, where it's either 1 dose or taking a series of these that a person can develop a severe like mitochondrial toxicity syndrome. She was put on gabapentin at the time by another provider because of the pain issues. The problem with this is with gabapentin, at the time she was getting an increased frequency in upper respiratory infections, and she wasn't able to tolerate really much of the back up here. This is the actual slide, gives you a little more history. So she wasn't able to tolerate much things orally at the time. So when she came into us, you couldn't give her B vitamins, you couldn't give her phosphatidylcholine. They would cause her to be nauseous and sometimes cause her to vomit. So oral regimens are very, very restricted at the time. So in that sense, if somebody comes into you and you don't know what to do and they are not able to take much orally, other than, like I said, she was on gabapentin at the time, and that made things worse, not better, you have to turn to oral strategies. So her GI symptoms started to get better after we got her off the gabapentin. And the way we got her off the gabapentin was truly doing intravenous nutrients therapies. With what I mean by intravenous nutrients is, I mean, there's vitamin C and zinc, minerals, there's B vitamins. It's kind of a complex mixture of B vitamins and other minerals and stuff, followed by glutathione and something called LAMC, or lipoic acid mineral complex, also called poly-MVA is the brand name. A big pivot we had in her case with fluoroquinolones at the time was using LAMC. Her case was improving, but it drastically improved when we added the LAMC to this situation. Doing those infusions allowed us to taper off the gabapentin because she did not have the pain anymore. And once we got her off the gabapentin, a lot of her GI problems started to improve. So we were able to get oral therapies in her and slow down the IVs. The other thing that happened is the upper respiratory infections started to improve as well. They were not coming on as frequently as every couple of weeks. If you read about the side effects of gabapentin, one of the side effects of gabapentin can be increased upper respiratory infections. So we did IV usage dosing on her. Now, this is something we did for cost-wise once a week with her. We did do this therapy for, I believe, close to 12 to 15 sessions. I also diagnosed her with POTS, had another colleague in neurology helped me with that with a tilt table, diagnose her with POTS syndrome as well. So in 2017, and this is, back then I knew about mold, but not too much. I was basically saying, okay, we know it's the really bad kinds, but we don't know the sensitivity and the severity. I think a lot of us were in that pivot. So in 2017 really is when she kind of tapered down, right? Things got better. We didn't need to do IV as much. She was doing it once a month. We did oral LAMC or poly-MVA. April, that's when we noticed, okay, you're having some mast cell activation issues that are worse seasonal. We did some antihistamine work and that did improve. And then the fatigue completely resolved in May. Now, I wrote an article on her actually in the Healpreneur for fluoroquinolone toxicity and use of this combo, but this fluoroquinolone toxicity has been around for quite some time, and it's rare, but it does pop up. Now, in 2017, we had a lot of fires up in the Pacific Northwest, and also and it flared her up. And I thought, okay, maybe it's the flare up of the fires and some respiratory issues, but that doesn't quite make sense. Her mother actually brought up that she'd been working at a summer camp, and in the quarters of the summer camp she was sleeping at, there was a lot of mold growing on in the log cabin at the time. And I said, whoa, what's going on here? You're doing very well, and all of a sudden you crash in the summertime, and most of your symptoms start to return. And she had an exposure of mold, it looked like, for a good week or two. And so we had to return her back onto these infusions with nutrients, glutathione. I think we were giving her about 1 gram or 2, and then lipoic acid mineral complex. Because of the mold exposure, we did more antihistamines. We also started doing a lot more binders. She was able to tolerate glutathione. She did bounce back. It took about 3 months to bounce back from that incident. But now what I'm noticing, and the reason I bring this case up to you, is what I'm noticing, and I think we're starting to see in the colleagues, is most of our patients who have things like fluoroquinolone toxicity or reactions to other antibiotics like penicillin or cephalosporins that are this drastic, oftentimes what I'm noticing more of is this is just the tip of the iceberg. It's just the thing that pushed them over the top. Most of them, when I work them up further, they often have a history of mold exposure. And I can't say because I wasn't looking at the time, but I do believe she had mold exposure prior to being put on the fluoroquinolone, and that just flared it up. And then she got re-exposure of the mold environment at summer camp, which clearly flared it up. So now she's very cognizant about her environment and avoiding mold because of her reactivity to it. And really, she reached out to us. So you see on here kind of the demographics. We had to use some parastigmine for her POTS, mainly typically like in the summer months. We had to use a low dose, 30 milligrams. And we found this helped kind of, so if she wanted to exercise, she didn't get these weird blood pressure changes and then heart rate changes. Other than that, she could walk, function, go back to work, everything was fine. So this drug seemed to help us with exertion and functionality and in doing things other than just your normal leisurely activity. We did follow up in 2018. She was working a stable job. Now, from 2014 to 2018, she was not working pretty much until that 2017 camp. She was not doing much at all with that first crash. Since she's moved to Montana, and she was generally stable. We did get a call from her about a month ago, and she checked back in after COVID, and the only thing going on is literally the exercise induction thing where she needs a little bit of that parastigmine during the summer months, mainly where she starts exerting and her blood pressure, she still suffers some POTS issues. But everything else is fine, and she's very diligent about avoiding, obviously fluoroquinolones, but mold-like environments. But I wanted to share this with you. One, so if you get an antibiotic reaction, you look for mold issues. Two is if you do get such a reaction where you're unable to do oral therapies, IV nutrition can really be helpful to bridge you up in this patient, moving them back in a correct direction. Because in those IVs, we were giving not only B vitamins and minerals, but we're giving her amino acids because she just couldn't eat that much. And she needed extra nutrition to really put on extra weight too. Now, this is very interesting. This is a more recent one. So this is a 56-year-old female, mitochondrial damage from mold. Now, this is another one. I saw her first March 2021. She reported that she got type 1 diabetes that was induced in 1987 after taking Naroxen, which is a fluoroquinolone. So she said, I have type 1 diabetes induced by fluoroquinolone toxicity. And so she initially came in saying, I have fluoroquinolone toxicity, please treat me. She was seeing another provider, and something didn't jive with her and the other provider, and then she found my office. And I got their notes, and they also proposed at the time, we need to do a lot of strong mitochondrial work. Now, she also, I can kind of see why maybe the other practitioner didn't jive. There is some compliance issues with her, and you have to repeat things quite often. So she didn't want to do any of the IVs, any hyperbaric oxygen at the time that was instructed by the other provider at the time. So when she came into me, I said, hey, those are all good ideas. If you have fluoroquinolone toxicity, that's definitely what I would recommend, starting with. But I said, let's look a little further with what I know now. So we did a bunch of reactivated viruses and found Epstein-Barr and Coxsackie. And I said, okay, that's interesting. You got mitochondria, you got a bunch of a few reactivated viruses. Let's dig a little deeper, because usually if there's reactivated viruses, Nowadays, if I see fluoroquinolone injury or antibiotic injury, I also say, well, there's got to be some type of probably mold involved. Let's rule that out too. So we did do a urine solvents because she denied anything in her home. And we did find strong amounts of aflatoxin and gliotoxin. I said, whoa, this is not good. That'll definitely make your mitochondria not work well, right? Let's not just blame the fluoroquinolones. Let's see how deep this goes. She was able to get an H-bot, mild hyperbaric soft chamber covered by her insurance. That was surprising. She was gung-ho about getting it covered, and she did all the work. I didn't have to do that. We did start her on phosphocholine and glutathione, like I showed you in that other patient, based on our mycotoxin profile. The other reason is we ended up testing her home, you see at the bottom there, further, and her humidity levels inside the home are running between 64 and 66 consistently. She looked further, and after denying it, saying, no, I don't have any mold in my home is fine, which most people will do. And she had mold that was growing underneath her bud frame. And she reported it growing on several walls in the basement areas where they would just wipe it up, and she didn't think it was a big deal. She found a kitchen sink that was leaking underneath, and there had been growth there. She had a daylight basement, which we all know is like death on wheels, and you got to watch those. And so they had some moisture issues behind the wall that they did. And then to cap it all off, which we found why the humidity was high and why there were so many issues, is this last winter, with all that snow and rain, she started to notice when it was melting, water would literally run down the inside of the windows. And this was something that a prior investigator went in and looked and did not catch. And she's an engineer, so she's pretty like, I want to find the root cause. I don't want to just band-aid this. I need to figure out what's really going on. Well, what ended up happening is whoever did the roof before did a poor chimney flashing job. So she had literally water running down inside the roof, and it would go down into the walls and then leak inside the windows. So, I mean, it's awful now, because literally now we're finding out there's mold growth up in the whole roof has to be redone. The walls have to be gutted. The chimney has to be redone. And there's also some poor sealing jobs. So humidity was getting into the house when it shouldn't be during wet months. So what we basically discovered is, holy cow, and you've been in this house for many, many years. How relevant was it really that the fluoroquinolone induced this? But mainly was it you were exposed to mold for probably back in the 80s in this house, who knows how long had been an issue, right? So because she wasn't able to get out of the house, and I wanted to do, and she was able to take things orally, it's also how long they're willing to do IVs. We just proposed, let's do phosphocholine and also do glutathione with her, just to kind of help, again, as a nice cholagogue, help for cellular support. And so that's what we used. Now, very interesting thing, and this was not on my radar other than, she said she traveled, but she didn't have any GI symptoms, is about the second infusion of phosphatidylcholine glutathione combination, she messaged me and sent pictures, and she had passed 2 14-inch tube worms also. I said, oh, that's awesome. That will definitely screw your GI tract up and mess things up even further from this. And my intuition on why this happened is because we always talk about most people, don't get worms unless they're immune suppressed, is probably upon her travels, because her husband didn't have the same reaction, is probably from years of having immune suppression from mycotoxin exposure in her home, led her to be more susceptible with biome issues and then get these worms that who knows how long had been in her system. And then just simply using some cholagogue, we did nothing to kill the worms. Like I said, no anti-worming therapy, nothing. It just literally, we did infusions of improving bile movement, and she flushed these worms out. So we just improved the microterrain, and she passed these things. Upon seeing that, of course, I did go through a more profound worm cleanse and parasitology testing. She decided to use herbal therapies versus deworming medication therapies. We did this for 3 months and really didn't see anything else come out at the time, but just wanted to make sure that it was done. So we're continuing weekly infusions now. She's been up to about 20, I'd say, since this has been written, maybe more like 25. Since this was made up, we have pivoted her to alternating using some poly-MVA or lipoic acid mineral complex. And the reason is at that stage, I do believe she can tolerate it. Before, I don't think she'd tolerate the lipoic as much, as easily. And one of the other IVs that I see, again, that people with mold really do well eventually with and feel well on is alpha lipoic acid. So lipoic acid mineral complex is actually it has alpha lipoic acid in it, but it also has your vitamin B1, and it has molybdenum and N-acetylcysteine and some of the other Bs in there that you need for full biochemistry to move. So that's why I've started to use that one over the other one. If you use alpha lipoic acid, now you have to track things like, is B1 sufficient or am I depleting it? But it's definitely an awesome therapy, alpha lipoic as well, as long as you're giving and substituting things like B1 for your patients. I do find that as a really helpful IV for mold-related or mycotoxin patients. So at some point, you will want to integrate that in. So now she's on a protocol where she does 1 week phosphocholine, and then the other week she does alpha lipoic. She didn't want to do them all on the same day because of the length of infusion time. And also for cost, she didn't want to do twice a week. Otherwise, I have no problem doing them on the same day or doing twice a week. I would be all for doing a little more aggressive. So that's why. She's not completely out of the environment. She's definitely has corrected the humidity issue and has corrected the current mold issue in the home. But she needs to fix basically the structural issues of the home, and then she's going to be doing the fogging treatments with enzyme therapies to get rid of the remaining mycotoxins in the environment. But she's got a lot more, like I said, fixing the chimney and fixing the roof issues is a lot bigger issue, and the daylight basement issue is a lot bigger. So now this patient right here, this is the mother of all patients. She's up there with one of my other ones. It's not mold related, but cancer mitochondrial issues. So this is a 75-year-old female. She had a history of, her husband's a dentist, and they owned a house with an indoor pool. And they had black mold, Saccharomyces exposure for, it sounded like 20 years before they knew it was there and knew it was a problem. She also has breast augmentation, and we know that she has basically implant illness syndrome. And she has a history of tick bites and diagnosed with Lyme disease by another practitioner as well. So in this situation, you know, the question always is do you treat the Lyme or do you treat the mold? Do you treat the breast augmentation or breast implant illness? And here's the thing. I always typically go after the mold and the toxicity issues, so then the immune system can start to function and handle the Lyme illness. Now, she came to me with quite a bit of severe body pain. Again, I actually put even longer on there. 40-year history, sorry. I thought this is 20, so even more. 40-year history of black mold with an indoor pool, silicone implants that were in 1987. So we know she's having implant illness, and then Lyme. Blurred vision, 60% since 2018. And literally, she's sensitive to everything. So plastics, glues from game boards and other things, carpets. She reacts to everything. So this is one that, you know, she doesn't tolerate medications. You can't give her things like T3 thyroid. She doesn't tolerate that very well. She gets really sick. You can't give her glutathione. She's one of those that only literally tolerates like milk thistle and yeast-free selenium orally. So, you know, what do you do with a patient like this who reacts to everything? And so basically our goal with her was, we need to increase bioflavonoids, milk thistle, and yeast-free selenium. We started there because we know her history. She doesn't tolerate glutathione. She doesn't tolerate drugs. She doesn't tolerate anything very well. She's not in the mold environment anymore in her house, so that's good. I will tell you that she was reintroduced to mold again later in this discussion. So then we focused on making sure that her foods were correct and she had no mycotoxin foods, and we were doing foods that were binders, and we did bitters. She could not tolerate most of the binders like charcoals, and didn't even go there with clays, but charcoals, even some of the benign binders, like some of the tincture binders that we might use with herbs, she just couldn't tolerate. So we just focused on basically food binders and bitters. So food binders being like lots of fibrous, cruciferous vegetables cooked. We focused on a dilution effect. So lots of healthy oils like olive oils, extra virgin, and also using lots of DHA. So DHA specifically, we're pushing this up to close to 2 to 4 grams a day, mainly for, again, that brain neurological function, along with kind to dilute out the existing mycotoxins and other toxins she has from the silicone implants. She did not tolerate any Myers-like nutritional protocol and PTC. She also reacted to, because of the soy and the stabilizing agents in there, extremely sensitive. So what do you do with this type of patient that reacts to just everything under the sun? What we ended up starting her with was just saline, literally desensitizing her and seeing, hey, how do you react to just an infusion of saline, 100 mils, and then worked up to 250 mils. After tolerating up to 250 mils, and again, 100 mils, we did it once a week for 2 weeks, and then she tolerated it. Then we went up to 250 mils for once a week for 2 weeks. And when she tolerated that, then we started to add dexpanthenol and slowly each week ramped it up. Now, why did I start with dexpanthenol? So dexpanthenol typically is one of your safer B vitamins. It also, it's the safest of the B vitamins. It is the least reactive of the B vitamins in an IV. It is also extremely important in supporting things like NAT2, which is in acetyltransferase, which allows you to break down histamine very quickly out of your body. So that was the other reason I want to do it. Any patient that has mold or toxins usually has problems with the histamine and histamine elimination. So that's why I added that to it. After that, we slowly started to assimilate thiamine med chloride. She did not tolerate med chloride. To my surprise, I thought she would have more problems with meg sulfate because of the sulfurs. So we ended up going to meg sulfate, compounded only, versus the manufactured version, because the compounding didn't have some of the stabilizers and the aluminum, low dose aluminum that can be found in there. Glycine, taurine, and then pyridoxine, and then a little bit of ascorbic acid. So we ended up going in that order, and what that would look like is literally a 0.5 to 1 ml of each thing, and we add that on 1 week. If there's any flare or anything that happened, we would continue that dosage until that would no longer be an issue, and then we'd add the next ingredient in from a 0.5 ml to 1 ml. So very slowly, we just titrated her up. She was stable with infusions for 1 year, doing that once a week. She was getting better. She's getting stronger. She came in literally in extreme amounts of brain fog and extreme amounts of pain. Her pain has been very well controlled by this time. The brain fog's still there, but it is improved as well. She still is very sensitive to things, so that has not gone away. So it was stable until they then noticed what they thought was a mold-free environment, because it was a new build. It was built like in 2019, I believe, or something around there. Condo, right? Well, unfortunately, the condo had an issue where upstairs a water heater was leaking right behind their kitchen area. It was upstairs, leaking all the way down the condo units. And they didn't know this for probably months. And then all of a sudden the water heater fully gave out and then flooded the area. And then when they opened it up, they found there was mold kind of growing in behind her kitchen. So then she had a flare there that set her back. And then it sent her to a friend's house up on the island here, Camino Island. And she also was exposed again at this friend's house because they had mold, I believe, in the attic of that house. So now she's in a hotel room, and she still has not been able to find, because of the housing market, a home. And her husband and her also have a lot of the equipment to like moisture meters and thermograms and stuff to look for this, because they know it so well and it's been so prevalent in their life. So they have not been able to find a home to procure that has what they need and also is mold free. Has been very challenging for them. So they're still in a hotel room. Now, the problem they're having in the hotel is the off-gassing of all the chemicals that are used in a hotel, from the carpets to the cleaners and stuff. So she's really struggling to get well. And she's actually, after those mold exposures and then the hotel not able to find a place to live, she's kind of regressed to the point we had to return all the way down to just 100 mils of normal saline and Dex 5. She was reacting to literally every single thing. She ended up also getting COVID the end of 2021, which, as you can imagine, everything flared up with that too. She didn't die or didn't get any severe issues. She did have a Guillain-Barré flare up from that, where she lost the inability to walk and was in a wheelchair for about a month to 2 months. She was able to regain that with hyperbaric oxygen treatments. And we were doing a lot of low dose remedies and some homeopathic remedies at the time. We also did add homeopathic vagus nerve D12 strength, which was significantly important in her cognitive and muscle strength changes. The interesting thing with this remedy is some people will do well if you continue to dose it. Others will get flare-ups after you dosed it a couple times. So 2 or 3 times is what I've noticed. So in her case, she was able to do it twice, and then after that, it kind of lost its thunder and it would flare her up. But those 2 times of doing it, it really did pull her out of this Guillain-Barré flare-up that she was having. And she was able to walk fully, and most of her cognitive decline has returned. Still spotty with short-term memory. Not surprising given the mold history and the silicone implant toxicity. Now, I know some of you are probably going to ask, why aren't you getting the silicone implants removed? Well, she's very frail, and the whole idea with giving her IVs was to try to eventually ramp her into doing amino acids and try to get her stronger so then we could get the implants dealt with. She's not strong enough to go through anesthesia and being put under and then having the implants removed. And that was eventually our goal. She was getting there until she got her 2nd mold exposure, then her 3rd mold exposure, then COVID. But now, since she's had all that, she's regressed and she's very reactive to everything. So we've had to pivot into a different strategy for her. Okay. So the reason I share that case, I'm still working on that case. I mean, 40 years of mold exposure unknown. I may get her to only a certain point, right? I haven't even touched the Lyme stuff. I haven't even touched the silicone implant stuff. That eventually will need to be addressed, but there's no way she'll deal with that right now. So in that particular patient, what do you do? And basically what I'm doing is I'm still continuing with my core selenium, milk thistle extract, some binders from foods, hydration, lots of therapeutic depuration therapies, hyperbarics. And again, IV saline is all she can really do. And then we're doing brain retraining of the limbic system. The reason I present that case to you is if you have a patient who has a long history of mold exposure or is very sensitive to anything, you do want to consider strongly doing a desensitization IV type series. And what this looks like is start with normal saline. Don't start with a Myers or PTC or glutathione or even NAD. Start very low and see how they do. Even just hydrating them is a lot, because we know a lot of these brain inflamed patients, they're not holding urine properly, right? They're over urinating, their ADH levels are off. So just giving them that alone can be very, very helpful. So start there. At 2 to 4 infusions, you feel like they're not flaring, things are going well, they're getting better. Then you can add your injectable of choice to the bag and slowly increase. Now, if they're very sensitive, I would recommend even like 0.25 or 0.5 mils and then slowly move up. So the reason I show you this is I wanted to give you this table of what I believe from my personal experience and working with my own patients, but also lots of other practitioners who have struggled to initiate IVs, is there are things that are more reactive and there are things that are less reactive in your mold, mast cell activated patients that you should be aware of. And you need to have a better understanding of therapeutically, what could I start with? So what this list is it's trying to give you an idea of if I was doing a desensitization, very slow infusion protocol, I would start with things like dexpanthenol, like I told you. It's a very safe form to start with, and then you can ramp them up. The other thing to point out is a lot of these IVs, they do come in multiple dose or single dose. Now, multiple dose vials have benzyl alcohols in them, or if you're not paying attention, some of them have parabens from manufacturers. Your mold patients will not do well with parabens at all. The benzyl alcohols, some of them may tolerate it if it's diluted down. A lot of them may struggle with it. So you may have to do single dose vials, no preservative in there whatsoever. And the downside of that is it's going to cost them a lot more because literally you have to chuck the bottle after you use it that day, right? So they're going to be paying for a lot more vials at that point. But that would be the ultimate best way, is to take all the preservatives out of the bag and just give it to them and then chuck the vials because that day. So this is an order of, I would start with like dexpanthenol, then we can start with things like taurine. Remember, taurine is extremely important in upregulating and supporting bile production. It also helps upregulate GABA receptor sensitivity. And most of these patients are going to have a lot of glutamate activity and very little or poor GABA receptor activity. The other thing taurine does is it's a powerful osmolyte. And if you're having patients who are inflamed, like mold patients, they have an incredible problem moving electrolytes across cell membranes and keeping them balanced on the correct side. So that's why I typically try taurine next. Glycine, it's not only generally calming, but it also is important in downregulating hyperreactivity or hyperexcitability of cells. So it works by hitting the GABA receptor sites. The other thing with glycine is it does support phase 2 detoxification processes. So those patients who are not able to tolerate something like glutathione, they may be able to tolerate glycine a lot better. Bicarbonate, and then we have things like biotin. I'm just going to run through these. Generally speaking, I find most people tolerate make chloride better than make sulfate. Now, that one case I showed you, it was the opposite. We had to make the switch. And so they tolerated meg sulfate, but most of the time it's meg chloride is a much safer starting point. Procaine can be utilized. Procaine actually is very helpful as remember, it's peripherally metabolized. It's not broken down in the liver like lidocaine. Some of the breakdown products of the PABA esters also do help support calming effects on the brain and kind of can quell some histamine-like activity. Minerals, hydroxycobalamin. Be careful with hydroxycobalamin. Manufactured hydroxycobalamin does have parabens in it. Then we have our other vitamin complexes. Now, on the other side of more reactive, notice I put phosphatidylcholine down there at the bottom. It can be reactive in your patients, but it goes up the list. Now, the other reason why people react to phosphatidylcholine is most of the time the carrier has to be dextrose 5%. There are some pharmacies that allow it at stable, normal, stable. What's the problem with that? Dextrose 5%. Dextrose is obtained from corn. Some of your patients may have corn allergies or may have reactivities to corn because of the properties of the mycotoxins in that. They cross-react and they have issues with it. So that's another reason. It may not be the phosphatidylcholine they're reacting to. It may be your dextrose 5% they're reacting to. So then all these other ingredients, and again, for time's sake, I'm not going to talk about all of them, but generally speaking, this is what I've noticed for how I would ACE into the least to most reactive patients. Quercetin is an IV that we can use. It is in a more advanced topic. It is tolerated up to 140 milligrams per kilogram. It's very rare that we need to go that high in a mold mast cell patient. Most of the time, you're going to go that high in an oncological setting. Resveratrol can be used as an IV as well. It is generally very tolerated at 50 milligrams per kilogram. Up to, again, we don't have to go that high. The potential concern is it does slow down phase 2 detoxification, which has a lot of sulfuration and glucuronidation properties. So that may be beneficial in some points, but also very detrimental in some patients. So in this series, I want you to think about, I always think of any condition I approach, just like mold. A formula. I have a formula that organizes my thought process. And this formula is M divided by T plus S equals R. This is methods. These are the steps you take, not the visits, not the infusions, but step 1 is, support detox. Step 2 is replace nutrients, something like that. Tools, what are we using? So supplements, labs, IVs is a tool. Skills is our training, and then results, how do we qualify, quantify, and measure? And this is with labs, physical diagnosis, or we may have machines that can help us diagnose and test this. Most of these people will need brain retraining. Their limbic system is totally off. So there's many online programs that help with maladaptive stress issues. And I find this is necessary in really sensitive patients. They will need this. They may need things like EMDR to help break through the trauma of the mold. I have a young kid who had 200 square feet of mold on the other side of the ceiling and down the wall because of the poor attic venting. And he has traumatic stress, not only from being exposed to mold for years, but this is a fairly new build, right? 2016, 17, poorly ventilated. But because of the whole process of going through remediation and living in a hotel, that was incredibly stressful for this child. So he needs things like EMDR, and he's doing also some retraining exercises. Another one I like for extremely sensitive is a homeopathic called Corcosinus, oak bark ash. This can be a very good starting point for people with not only food reactions, but also other histamine intolerances or reactivities. I've used this a number of times before the patient, if they have a sensitivity, extreme sensitivity in an IV even, it has cut off the need for things like Benadryl as the next step in some patients. Any vagal nerve support, I'll let you read through the list just for time. sake, but you must, these patients, absolutely everyone with mold needs some vagal nerve support at some time. They're in the full fight or flight. Lymph support, dry skin brushing, rebounding, and to be honest, I'll tell you, even all the oral things you do, number one thing I found for lymphatic motion and movement is electrolymph or something like a lymph star. In patients that don't move their lymph very well, that can be the game changer for them. And if you're doing all this good biochemical stuff and moving toxins, you sometimes, most people will forget about the lymph, and they need that to be working for this person to move forward. So what you need to do with this information is basically, I call it your roadmap. You know, take this information and build your treatment equation and build your roadmap. IVs is just a tool among all the other things and all the others you might have been listening to. But it's a very, very helpful and powerful tool. But if you just do IVs alone and do nothing else, again, it is a tool. Just like if you gave somebody one thing and said, this is going to fix everything, you're bound to fail. So utilize this information as a tool within a larger equation, and then you can build a roadmap to get the patient from the trenches or the mud into a successful treatment outcome. Thank you.
That was a great talk. Thank you, Dr. Cochran. I don't say this often, but I'm going to definitely have to like rewatch that. There was a ton of information there. I'm going to have to like pause it in between each talk to like write down. Luckily, I have all the slides, so I don't really need to like copy the slides. But for everybody else, we will be putting this online probably in the next day or two. So it'll be up on our website because I know there's a lot of information there, and you're probably going to want to come back and take notes. So if anybody has any questions, please put them on the Q&A on the bottom of the page. There was a couple of questions here. Dr. Cochran, I assume you have a couple minutes.
Yeah, please.
One person said, we use essential towel and put it in D5 250 mils.
Yeah.
Are you using a different product or putting it in NS? Yeah,
so I know the Essential in product. Here's the only issue with that. It's not available in the US unless you order it outside of the US. If this question's coming from somebody outside the US, don't worry about it, use it. In the US, we're not supposed to be importing that because it's considered importing a drug without, and you'll get a cease and desist if you do that, so don't have it shipped to your office. There is a person in the US that has a wholesale license. It's called Plaque X. It's exactly the same constituent. They import it from overseas and they have a wholesale distribution. It's Anazoa Health, or Anazoa, I believe, is the pharmacy there in Florida and Nevada, and they make Plaque X and they have the distribution rights for it. I have found that upon talking to them is stable in normal saline and have not had issues with it. You can use it in either D5 or normal saline. Again, anytime you inject it in there, initially it is a little white cloudy, but it's not milky or precipitate. You'll know if the PTC is not reactive. One, the pharmacy will say absolutely do not use anything else but D5W. Two is if you put it in there, it gets this milky, creamy versus a kind of a more distorted color. It's very distinct that it's precipitating. And that's what I use. And I do use 250, sometimes even up to 500 or 1,000 mils. Again, the sicker the patient, the more dehydrated they are, I'm happy to put more fluids in them. They'll tolerate a lot better. But yeah, that's what I use currently. That's what we can get in the United States. I think both of them are adequate and work well.
Next question. How about oxidative treatments for mold?
Yeah, so oxidative treatments, I didn't talk a lot about it. Maybe I'll talk about it in the June conference if we wanted. I tend to shy away from starting there. If you're talking about things like ozone, hydrogen peroxide, or high dose vitamin C, I don't start with high dosages of ozone. I may use a low dosing strategy. I can explain it briefly and then maybe elaborate on it in our future discussion. Ozone, most people just think they just get ozone and it's one dose. There actually is a dosing strategy of high and low. Low dosages, I find, are very helpful in increasing a person's body's ability to upregulate their antioxidant buffering systems. High dose does not do that very well, and you can obliterate and make your patient very sick. So I tend to shy away from my mold or hypersensitive patients doing strong oxidative therapies at the beginning of the treatment. This may be something that I'm able to do more of, say 6 months or a year into treatment. I may be able to ramp some of those things on board, but I tend to avoid them as these patients need a lot more antioxidant support.
Cool. Let's see. I think I got one more question here. Is the Patricia Kane protocol same as PPC treatments?
Yeah, so there's another protocol out there that uses PTC. They use a push protocol where they mix blood and then they push it back in. I know that there's different opinions, and so I don't get myself into trouble by saying something bad. I'm just going to say my opinion and some of my other colleagues is I don't find there is a significant clinical value of mixing it and pushing it into a person's vein. I find that just doing it as an IV in fluids, you get the same clinical benefit and less vein irritation and problems. So that's what I do.
Cool. Well, if anybody has any additional questions, feel free to email us at the Mold Pros. Then we'll push the questions off over to Dr. Cochran. Again, thank you everybody for joining us. Thank you, Dr. Cochran. Really appreciated your wisdom on this. It was a great talk, and I'll be excited to see you in the future.
All right. Thank you very much.
Okay. Bye, everybody.
Bye-bye.